Hi, and welcome to the July 2026 DermSurgery Digest podcast. I am the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Spotlight podcast focused on cosmetic and general dermatologic procedures, we have Ardalan Minokadeh from Skin Care and Laser in Los Angeles doing the in-depth article summaries, and Kristel Polder from Dallas Center for Dermatology and Aesthetics as the senior expert editor with commentaries. Please don't forget that we continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic-focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Welcome to this month's DermSurgery Digest, where we'll review the cosmetic leaning manuscripts from the journal Dermatologic Surgery. I'm Ardalan Minokadeh, ASDS member and dermatologist practicing at Skin Care and Laser Physicians of Beverly Hills in Los Angeles, California. Today I'm serving as the junior editor along with our esteemed guest contributor, Dr. Kristel Polder, and we've selected 3 of the manuscripts for a more in-depth discussion, after which we'll give high points and clinical pearls from the remaining manuscripts. I'm truly honored to introduce Dr. Kristel Polder, a partner at the Dallas Center for Dermatology and Aesthetics and clinical professor at UT Southwestern. She is widely recognized as an expert in cosmetic lasers, injectables, and skin rejuvenation. She's co-author of the book Beautiful Skin Revealed and a highly sought-after speaker who has lectured at numerous national and international meetings. Beyond her private practice, she's deeply committed to mentoring the next generation of physicians through extensive leadership roles within the ASDS, and most notably, she's served as expert faculty for over a decade at the prestigious ASDS Premier Annual Resident Cosmetic Symposium, where she leads hands-on injection training and lectures to top dermatology residents from across the country. Welcome, Dr. Polder.
Thank you so much, Ardalan, for that amazing intro. I'm honored to be here.
Of course, thank you again. So we'll get started with the first of our 3 highlighted manuscripts. The first one is Practice versus Protocol, a survey of current botulinum toxin use during lactation and pregnancy in dermatology with the associated commentary from Dr. Ishii. So this is a cross-sectional study looking at botulinum toxin A administration practices during pregnancy and breastfeeding among U.S. dermatologists. There were 177 respondents that actually showed that 20% of them did administer this treatment while patients were pregnant, and 75% administered them during breastfeeding. Ultimately, no adverse events were reported. We're aware that classically this is considered a Category C medication, but with the newer pregnancy and lactation labeling rule, or PLLR, it says it should only be used in pregnancy if potential benefit outweighs the risk. And the authors do highlight that much is still unknown because of the lack of high quality data. I'm curious, Dr. Polder, what is your current protocol or practice with respect to pregnant and breastfeeding patients? And does this manuscript mirror your thoughts?
So first, I want to applaud the authors for surveying our colleagues on how they practice medicine, because there's probably never going to be any sort of large-scale study on this patient group, your nursing and pregnant patients. So in our practice, I've been in practice 17 years. We're majority cosmetic at my practice, and we do a high volume of neuromodulators of all types. And what we currently do is we have patients that are nursing. First of all, we don't inject patients that are pregnant. That's a risk tolerance thing. And I think that's reflected with the group because you saw only 20% of the physicians surveyed, which is only 33 of the 175 individuals, do that. And so we just have a policy where we don't do any elective cosmetic procedures on our pregnant patients. And that includes energy-based devices as well. But what we do is we have them pump and dump. And our reasoning behind that is very similar to what the article stated, in that any molecule over 800 Daltons and your, Bonti, any of the Bontis are going to be in the 150 kilodalton range. it's going to have minimal impact on that breast milk. But if there is a little bit that ekes through, if you pump and dump one cycle, most of the neuromodulator is taken up within the first 30 minutes. And so our thought process is we inject them. By the time they get home, it's probably over 30 minutes. So that was the reasoning there. There's no data to support that, but that was more for our comfort level, and we're a very conservative practice. But that's how we do it here.
That's wonderful. Thank you so much for your insight. No, that's really interesting that you're right. There likely will not be any large randomized controlled study, but great points. Thank you.
I think with all of these things and elective procedures in our patients, you're sort of, if there's a complication or an issue, which there has never been in our practice. And like I said, we do a high volume of neuromodulator injections. And our practice has been in operation 33 years. So we have yet, and I'm going to knock on wood, have had any sort of issue with that policy. Now, according to this literature, you could not have them pump and dump one cycle. And I will tell you, me personally, I am a mom of 3 sons. I had Botox and other neuromodulators throughout nursing, and I nursed for a year with each son. So that's 3 years total. I forgot to pump and dump on one of the sons, and it's the wild middle son. So
Oh my
I'll
God.
let you kind of figure out if that was related. But the other 2 are just like perfect angels. And the wild middle child, of course, is the feral animal.
That's so funny. Oh my goodness. Thank you. All right. So next we'll move on to the second of the 3 highlighted manuscripts, which is establishing a vocabulary for skin quality, working towards consensus skin attribute definitions from the patient and physician perspective. And this manuscript also has an associated commentary from Dr. Daniel Schlesinger. Now, in this manuscript, the author's goal was to develop a skin quality vocabulary applicable to the variety of those of us interested in this field, not only clinicians, but also patients and regulatory agencies. Figure 1 shows the initial proposed listing and domain structure. Secondly, in Figure 2, they show the methods of this manuscript, which was several advisory boards with many, 15 specifically, global aesthetic dermatologists to develop consensus definitions. These definitions are shown in Table 1 with specific details as to how they define these terms. The goal was to define these terms and serve as a foundation with consistency that will support not only interclinician communication, but as I mentioned, with indication approval for regulators. Interestingly, the commentary, Dr. Schlesinger says that if a patient were to tell him, just make my skin look like a glazed donut, that may mean different things for different people. So, Dr. Polder, what's your view on skin quality? How do you define it? And do you think that this was a practice gap, so to speak, that really was necessary to be addressed?
Well, I think this is really important work, and I think this is an amazing first step. So let me give you a little backstory. So I was one of the 14 clinical trial sites for SkinVive, which was in Canada called Volite, and had previously been cleared in Canada for about 8 years before we did the pivotal trials, phase 3, here in the US in 2018. And we struggled in the phase 3 clinical trials with the terminology. And let me tell you why. Because in the study, the FDA likes metrics, right? They want to see a 2-grade improvement. That is how everything gets FDA cleared, whether you're talking about eczema or psoriasis or toenail fungus or whatever. They want to see a 2-grade improvement. And so we need something very objective for our primary endpoint. Secondary endpoints, they talked about some of the terminology like glow, hydration, radiance, perception, quality of life surveys. All of that was in the secondary endpoints. But the primary endpoint in the study was for cheek lines. So that was what we were injecting, what we were essentially looking at for the FDA. And then once it was FDA cleared, sort of the rest is history with respect to SkinVive being a skin quality treatment. So if the audience doesn't know what that injectable is, it's microdroplet, low G prime, low molecular weight hyaluronic acid product that's injected more as a skin quality treatment to improve the hydration of the skin. So it's like an internal moisturizer. In the studies, we used moisture meters and all of that. And Shannon Humphrey, who's the lead author on this paper, was the one who did the studies back in Canada. So she has pretty much a decade more of experience on the United States, which is why she is uniquely positioned to be the first author on this paper and for it to be so near and dear to her heart. So the first thing to know is that it's very difficult when communicating not only with healthcare providers, but definitely patients, and definitely patient to patients, communicating this type of terminology. And I like that they divide it into four main characteristics: visible, which would be like redness, dullness, sallowness, radiance; topographical, roughness, fine and coarse lines, dryness, and pores. That's something that people come in, that's their chief complaint all the time is my pores are very visible. I want to work on this. Mechanical refers to the elasticity of the skin, the firmness of the skin, the thickness, the pliability. And then last, your sebaceous equilibrium, meaning oily or dry skin. So I like that there's now defined metrics and subsets which we can build upon for the future. I know that they went in and looked at, they had these patient focus groups and surveys in this study asking healthcare to provider, is there concordance among what you understand these terms to mean? And there was. And we would expect that speaking with medical terminology, healthcare provider to healthcare provider, but there's a severe breakdown in communication when you go what the healthcare provider sees and what the patient sees. How can we do some of these treatments if we don't even know what the metric is, right? Um, the other thing I wanted to say is this is the beginning. I think, if you look at TikTok, if you look at Instagram, there's a lot of filler fatigue out there. I think people don't want to look overdone, especially millennials and Gen Z. And I think skin quality is going nowhere. I think that meaning it's here to stay. And nowadays, I would say more elevated look is amazing skin quality, which is coveted all over the world. So this is something that's here to stay. I'm glad that Dr. Humphrey and the other authors are pioneering and leading the charge. It sounds like Murad Alam is also doing a lot in this space as well. The commentator mentioned that as well. So I'm excited. I think we're ushering in a new era of really natural, beautiful looking skin.
That's wonderful. Thank you so much, and thanks for sharing your personal insight with the clinical trial you were referring to.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendar as out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
Next, we're going to discuss the manuscript comparing a red and blue LED light device with an existing blue light device for at-home treatment of inflammatory acne, along with the associated commentary as well. So we're aware that blue and red light have beneficial and often complementary effects on acne. And this was a study looking at the efficacy and safety of an at-home treatment with respect to mild to moderate inflammatory acne. There was an investigational combination 660 nanometer red and 415 nanometer blue LED device, abbreviated as RBL, which is shown in figure 1, compared with the commercially available 415 nanometer blue LED device. This was open label, randomized controlled trial with 20 subjects getting treatment once daily for 8 weeks, and there was a 4 and 8 week follow-up. Ultimately, it was shown that the daily at-home treatment with the red-blue combination light LED showed significantly reduced inflammatory and total acne lesions at both the 4 and 8 week time point. And you can see the lesion count changes in figure 2 and the decrease. And figure 3 showed a representative before and after demonstrating improvement clinically. The red and blue were equivalent in most outcomes, but the red and blue combination showed a significantly greater reduction in the median investigator static global assessment. So, Dr. Polder, I'm curious because this is very timely. LED therapy is very hot. Red light masks are a hot topic. I get asked about that all the time. Can you share your thoughts on this manuscript and give us some insight on how you counsel your patients and feel where this type of device is within your protocol?
Well, the first thing to say is you're right. I even feel like I have targeted ads to me constantly for all of the red light masks. In the article, it does state this, the market for this is going to be almost $3 billion in
Wow.
2034. So this is exploding. And I think it appeals to a lot of patients that maybe they're working from home. I think more people post-pandemic are working from home or partially working from home, and they've got this extra time and they want to make good use of it while they're working. And so they'll do their light treatment, pop on their red light mask, and go from there. In the study, they saw efficacy with both devices, so the combined red and blue, and then also the blue as a standalone. And if you look at the name brand of the blue light, that's a name brand that's been around for a very long time, since I first came out into practice, so over like 17 years ago. Another brand that you see a lot is Omnilux. That's not in the study, but you see it over and over. And that was a brand that was around, 17 years ago. So these devices are getting better and better. That being said, by the time the patient gets to the chair in my office, usually those treatments have failed and they're seeking a next step. So I think it's nice for the patient that's going to be consistent, that's going to utilize it. In the trial, it was daily. I personally don't have time to do something daily. I know in the commentary they mentioned other devices which were more of a mask. This was a handheld, which has user error. Obviously, the patient had to direct it at each cheek and then the forehead area. And in the study, there were 2 cases of a first-degree burn. So these treatments are not innocuous, meaning you're still delivering energy to the skin. And so I think, making sure that you're following directions is important. Perhaps using a mask may eliminate some of that variability, but then also having the time to be consistent to see results. A weakness of this study, I see a lot of skin of color in Dallas, Texas, and that was excluded from this study. It was only fits 1 to 3. So that is a group that has been reported to have post-inflammatory hyperpigmentation from these devices. And I think we need to be very careful if it's a melasma patient or a patient with hyperpigmentation to suggest these things, because there can be some error there. They can get PIH from the device. So.
Wonderful. Thank you for your insight. And those are great, kind of palpable, tangible pearls we can take. Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.